Hello everyone, my name is Dr Arvind Vatkar. I'm a consultant orthopedic spine surgeon working at Adi Life Polyclinic in Chembur and Fortis Hospital, Vashi. My today's topic is about spine problems, what you need to know as a doctor. Okay, so the topics which will be covered will be intervertebral disc problems, spinal stenosis, spondylolisthesis, cervical myelopathy, fractures of the spine and log rolling, and spinal orthosis, the types and indications. In terms of the intervertebral disc problems, now let's delve into that. So this is an cadaveric model of the intervertebral disc. Now these are present between two intervertebral bodies. So it has two parts. One is known as the nucleus pulposus, which is a jelly-like material, okay, which is present over here, and you have the annulus fibrosus, which is a fibrous band-like material which surrounds the nucleus pulposus. It is relatively avascular and it maintains the stability and the movement in the spine. Okay. Now, if you see this study by Nakimson, in which he showed that if about 100% is the pressure which is on the 3-4 intervertebral disc on standing, if you sit and bend forwards, you will have about 2x or twice the amount of pressure on your back, and this increases the chances of disc prolapse. Okay, similarly in this photo you can see that if you on lying down your pressure is about 25 pascals while lying down. As you stand up it becomes 100, and as you sit and bend forwards with some back it goes to about 275. So the high risk jobs like weightlifters who don't do their weightlifting by a correct technique, or desk job IT workers who are sitting for long period of time, have high risk of prolapse intervertebral disc. Now, what is basically an intervertebral disc herniation? So, as you can see over here, this is a normal disc in which you have this jelly-like material and you have this band fibrous area around it, and you have these nerves and a collection of nerves which is known as a dural sac or spinal canal, uh, and you have these nerves coming out from here. Now, when the annulus fibrosus, which is this part, this fibrous part, which cuts open or which breaks, and this jelly-like material starts going down and it starts compressing on the nerves. Okay, now this release of this nucleus pulposus can be in the center, can be posterior center in the back, or can be lateral, depending on which the nerve will be compressed accordingly, and this causes compression of the nerves or the dural sac or the spinal cord. Okay, now in terms of the classification of the disc prolapse, you can see first is the disc degeneration which happens. Second will be there will be tear of the annulus fibrosis, which causes a bit of prolapse of the nucleus pulposus. Then there is a proper prolapse, and then it comes out more, known as extrusion, and when it completely comes out from the disc it is known as an sequestration. Now, what are the causes? It has multifactorial causes like repetitive mechanical loading, trauma, sedentary lifestyle, very common, obesity, very high chances of reherniation after the surgery also, poor posture, and addictions like tobacco. Now, what generally happens in an intervertebral disc? You will have pain in the back and it will radiate down to your legs. Okay, based on what is the level of the disc, you will have pain in the thigh. If it is an L1 T12 L1 disc, you will have pain in the thigh and just below above the knee in L2 disc compression, L2 nerve compression. You will have pain around the knee in L3 nerve root compression. The most common, you will have pain along the lateral side of the leg, which is in L5, and is if it is on the medial side it might be the L4 nerve root. Okay, once the nerve is enough compressed it will start causing numbness and later on it can cause weakness also. If the nerve is significantly compressed and along with that all the nerves in the dural sac are compressed, okay, it can cause bladder symptoms like urinary incontinence or urinary retention, which is known as cauda equina syndrome. In terms of the treatment, rest and medications are important. The rest is generally limited to 1 or 2 days. With medication, the pain goes down, and after that, you need to continuously do exercises which are like pelvic lifting exercises, abdominal crunches, back extension exercises, and plank exercises. Even with rest and medication, like IV medications, pain medications, the pain is not getting relief. Okay, then we can give epidural steroid injections, which is a needle which goes near the nerve affected, which is based on an MRI finding. And then later on, once the injection is given, the pain goes down. Later on we can do exercises, but the prerequisite of epidural steroid injection is, first of all, it should be just pain. There shouldn't be any weakness or any neurological deficit like gallbladder symptom before we embark on epidural steroid injections. Okay, and in terms of the surgery, so the surgery indications are, even after 3 weeks of conservative management, you didn't get any good pain relief, your problems are increasing, your pain, radicular pain is increasing even after medications, and you have a neuro deficit, then you might go for a surgery in which we remove a part of the bone which is known as a lamina, and we decompress the nerves by removing the part of the disc which is compressing on the nerve. Okay, going forwards, now I'm not going to discuss more about the surgery as such, but about the post surgery care, which is very important for doctors and for patients in itself. So you need to maintain pain control. The second thing is you need to see for neuromonitoring. That means you have to see if there is any neurological deficit post operatively. Third is you have to mobilize the patient as early as possible, because the more early you mobilize the patient, the better it is in terms of their lung function, and you get less chances of deep vein thrombosis. If you have a dural leak, that means the nerves are enclosed in a sheath which is known as a dura, and in that dura, inside it is a fluid which is known as a cerebrospinal fluid. If you get headache or if you get photophobia, that means you have high sensitivity for light after surgery, you might have a dural leak. So in these conditions, we check the wound again if there is any fluid coming out of it, and the patient might require bed rest for about 2 or 3 days before we start mobilizing the patient. In terms of the deep vein thrombosis, again, patients who have got previous surgeries like hip replacement, knee replacement, or who have got a previous history of DVT are at a higher risk of deep vein thrombosis. That itself makes it very important to mobilize the patient early. In terms of the gallbladder, we need to see that the patient is able to pass urine properly after the catheter is removed. He is able to open up his bowels regularly. Antibiotics, I'm not a very great fan of giving antibiotics for a long period of time. Okay, so if it is a clean surgery, I would give 1 or 2 doses of antibiotics. If I put any screws, which is instrumentation for fusion, I might give it for 1 or 2 days. Okay, so lastly, surgical drain. If there is any CSF or any increased blood collection in the surgical drain, we might have to keep it for a longer period of time. Or if it is just a few ml, about 25 to 50 ml in 24 hours, we generally tend to remove the drain. Okay. Now, post-op fever, very common to have post-op fever. So generally, a lot of people get panicked if they get fever after surgery. But till it is like day 4 or 5, you shouldn't be really panicked that your surgery at such is a problem. Okay, so day 1 fever is mostly because of atelectasis. Now, what is atelectasis? Is it's generally a mild infection which happens in the lungs because of the collection of fluid in your lungs. Okay, some rare causes of day 1 fever are thyroid crisis, allergic reaction, or malignant hyperthermia. Okay, you can also have day 1 fever if blood transfusions have been done. Okay, now what do you do for atelectasis is just simply you need to have a good chest physiotherapy, you need to make the patient propped up properly, and early mobilization is important. In day 2, 3 fever, it may be because of indwelling medical devices like urinary catheter, IV catheter, chest infection, and rarely tissue necrosis and gout. Okay, if you have that, you have to change your IV catheter, remove your Foley's catheter as early as possible. Chest physiotherapy and early mobilization are of paramount importance. Okay, day 4 and 5, definitely you have to think about wound infection, in that the surgeon has to hang in and check for the dressing. You have to consult your doctor, and blood investigations are required to see if there is any increased WBC count, which could be a telltale sign of infection. Now let's come to specific, which is known as lumbar canal stenosis. So as you can see over here, if you have a long 6-lane road, your traffic seems to be completely all right. But even if you have a 6-lane road, and if you have an car which is just locked over here, or a car which is just broken down, you might have a lot of traffic. Similarly, over here, what happens is, like, because of the ligamentum flavum hypertrophy and the osteophytes and the facet joint hypertrophy, the area through which the nerves are passing, that gets decreased, and that causes lumbar canal stenosis. Okay, so what are the symptoms in lumbar canal stenosis? Is first, whenever the patient starts walking, slowly and steadily he will start having increasing pain in the legs, he will have numbness, and he will have heaviness in the legs. Okay, after which he has to sit down, and once he sits down and bends a bit forwards, his pain will decrease and he can start walking again. But this cycle of pain on walking keeps on happening, and the distance gradually keeps on decreasing till the point the patient is not able to walk. This is basically lumbar canal stenosis. Okay. Now you need to differentiate this from vascular claudication, which is basically because of prolonged smoking and because of atherosclerosis of the arteries in the legs, which causes more pain in the legs. And this is not actually correlated with any exercise as such. However, when you're walking, your leg pain starts first and then it goes in your thighs, and there is no pain in the back. Okay. Now, in treatment of lumbar canal stenosis, what generally it is seen is that lumbar canal stenosis is inherently not very unstable. Okay, so treatment wise, 90 to 95% of the patients can be managed with medications and exercises. Okay, if there is no improvement, we can give caudal epidural steroid injections, which is an injection of a big volume medicine given through the small area in the sacral region. Okay, and last resort is a surgery in which we decompress the nerves by removing a piece of bone from the back and decompressing the nerves, the sheath of the nerve, which is known as a dural sac. Okay, now let's come to spondylolisthesis. This is slightly different than lumbar canal stenosis, in which the compression of the nerve is basically caused because of slip of one vertebrae over the other. Now here you can see there are two types of spondylolisthesis. So there is degenerative spondylolisthesis, in which there is degeneration and separation of the facet joints, which are the joints behind, and that causes the compression of the dural sac. Okay, and then you have the lytic spondylolisthesis, in which there is a fracture or a separation of the pars interarticularis, which is an connection between the vertebral body and the posterior segments like the spinous process and the lamina, which is known as pars interarticularis. Okay, so this causes compression of the nerves and the dural sac. Okay, now what are the causes of degenerative spondylolisthesis? As I told, first is because of the disc degeneration, there is segmental instability, and then there is arthritis of the facet joints. As you can see over here, there is arthritis of these facet joints. Additionally, there are some osteophytes also which are compressing on the nerves, and the ligamentous complex also fails, and the muscles are also weak. This causes inherently an instability in that segment, and that causes a shift of the vertebrae one over the other, causing decrease in the diameter through which the nerves are passing in the dural sac, and additionally it also causes compression of the nerve which is coming out. Now, what are the symptoms in spondylolisthesis? Well, there is compression of the nerves, which causes radicular pain. There is compression of the dural sac, which causes neurogenic claudication. You have facet arthritis, okay, which will end up you having back pain. And in the later stage, you might have weakness in your legs and also have ball bladder symptoms. Now, what are the investigations? What we can do in this is, first we do an X-ray of LS spine, AP and lateral, in which here you can see there is a spondylolisthesis in which your vertebrae is shifting, or this L5 vertebrae is shifting over S1. Again, if you do an flexion extension view, this is a different X-ray in which you can see that on extension, on flexion, there is a slip of L4 vertebra or L5 vertebra, and on extension there is instability. That's why it is coming back to its position. Additionally, you can do an MRI of the LS spine with whole spine screening, where you can see over here that there is compression. On axial images you can see there is compression of the dural sac, and additionally your facet joints are also fluid filled, which is a telltale sign of arthritis in the facet joint. In terms of the classification of the degenerative spondylolisthesis, so you have this as an healthy one. You have grade 1. This is slightly wrong. It is about 25%. Okay, so if you have 25 to 50%, that is grade 2. If you have 50 to 75% of the slip of the length of this vertebra, then it is grade 3. And if you have more than 75%, it is grade 4. And as a cartoon shows over here, this vertebra can just topple over the lower vertebra, which is known as spondyloptosis. Now, in terms of the natural history, you can see you will have pain and radicular symptoms. Sometimes this vertebrae, one over the other, if the disc degenerates significantly and the vertebra above and below, they get auto-stabilized on themselves, and there is no instability as such. Okay, there is less chance of progression. Okay, this also happens. So that's why flexion extension X-rays are important, and there is no correlation of the radiologic slip and symptoms. Hence, you need to know, even if there is a stable spondylolisthesis and the patient doesn't have any radicular symptoms, you don't need to go forwards with the surgery. Okay, in terms of the options for surgery, again, about 90% of the patients with spondylolisthesis can be managed with exercises, and core strengthening exercises are important. And you can also go for a traditional way of compression, decompression, plus minus fusion, which could be instrumented and non-instrumented fusion if the patient has significant problems and has got claudication which is not getting relieved by medications and exercises. Again, for patients, nowadays we do minimally invasive spine surgery, in which we don't have to actually cut open the whole of the muscles. We can just pass the screws with the help of x-rays, and we can decompress the nerves and put the cage inside with the help of tubular retractors or endoscopy. Now, cervical myelopathy. Again, this is a condition where the spinal cord in the neck region is compressed because of a disc, or because of osteophytes, or because of bony formation. Now, the overview is it is one of the most common cause of spinal cord dysfunction in individuals above the age of 55. As you can see over here, this disc is compressing on the spinal cord, and this causes cervical myelopathy. Okay. So now what are the causes of cervical myelopathy? It is more or less similar to lumbar canal stenosis in the lower back, but here your spinal cord, which is high up in your neck, is getting compressed. So the degenerative changes are like cervical spondylosis, which is an wear and tear of the cervical region leading to spinal stenosis. The other causes are disc herniations, as you can see over here, the disc herniation, as you can see over here, the bony spurs which are hypertrophic. Okay, those can also cause. There could be ligamentum hypertrophy, and there could be spondylolisthesis, that is shift of one vertebrae over the other, causing a compression on the spinal cord, and sometimes even trauma can cause that. Now, what are the symptoms you can have in cervical myelopathy? First of all, you will have neck stiffness, you will have neck pain, and you will have numbness and tingling in your hands and legs. You might feel that you are walking on a cotton kind of feeling. Okay, you will have loss of dexterity of hands, so you will not be able to manage the day-to-day activities that efficiently as you used to be doing before. You might have symptoms of fall of objects from the hands, unsteadiness, and repeated falls. Now, what are the neurological symptoms? What a doctor might elicit is weakness in the arms and hands. You might have exaggerated reflexes both in lower limbs and in upper limbs. You will have Hoffman's positive, which is a telltale sign of exaggerated hyperreflexia. And lastly, you can have extensors, uh, plantars as extensors, which is an Bambiskis kind positive. In severe symptoms, you will have difficulty walking, you will have loss of fine motor skills like using spoons, buttoning and unbuttoning your shirts, and bladder and ball dysfunction can also come in the later stages. Now, what you do in this, in terms of investigation, you should have a clinical suspicion, plus you should get an MRI and an X-ray, in which on MRI you can see over here that the disc and above are compressing. You also have a bit of ligamental hypertrophy and a bit of osteophyte formation, which is compressing on the spinal cord over here, and this could be the classical sign, could elicit classical signs of cervical myelopathy. In terms of the treatment, again, conservative management is the first go. You do physical therapy in which you do exercises and you start the patient on medications, and sometimes you can start on a short dose of steroids. Again, in terms of the surgical intervention, you can go for decompression surgery, spinal fusion, and laminectomy, which is a part of the bone on the backside, which is removed to decompress the spinal cord. In terms of the post surgery rehab, you have to do physical therapy and restore the function and mobility, because these patients, whatever they have lost in terms of the function, that needs to be brought back by physiotherapy and occupational therapy. Okay, now this is one of the cases what I had done before. Here you can see this is an 50-year-old lady who had severe compression of her spinal cord, as you can see over here, right from the levels of C3 and C2 to about C6, C7, and on MRI also you can see the spinal cord is squished because of his huge bony formation. This is from C2, C3, C4, C5, C6, and C7. As you can see over here, at every stage there is compression of the spinal cord because of the ossified posterior longitudinal ligament, which is known as OPLL. Now, this patient had significant weakness on her right side, and she had some weakness on her left side also, and she was not able to walk properly. So what we did is we decompressed the spine. As you can see over here, we decompress the spinal cord by doing an laminectomy, which is removal of the posterior part of the spine, and because we have removed the spine from the posterior side, basically the bone from the posterior side, we have fixed it with screws which are known as lateral mass screws, and after that the patient did really well. She still has to come out of her weakness, which will happen slowly and steadily in terms of physiotherapy. Also, in terms of the causes of distal neuropathies, which are kind of confusing neuropathies, you can see that polyneuropathy is one of the cause, in which diabetes, if the bloods are really high and the patient has got diabetes for a long period of time, they can have numbness, pins and needles in the legs and hands, which can be confused with cervical myelopathy and sometimes with lumbar canal stenosis. You might have simple B12 deficiency, which can also cause distal neuropathies, HIV and cancer related and autoimmune disorders can also cause distal neuropathies. Now let's delve into the fractures of spine. Now, what are the causes of fracture in the spine? First is traumatic, which is common. If you have a road traffic accident or if you have a fall, you can have a fracture of the spine. Now there are other causes which are pathological, in which the quality of the bone is deficient, because of which even on normal loading the patient might have fractures. So for example, osteoporosis in old age can cause fractures of the spine, mostly at the dorsolumbar or the thoracolumbar region. Infection can also cause weakness in the bones and cause fractures. Tumor can infiltrate into the bone and cause weakness and cause fracture. And lastly, metabolic. If your uh, bone physiology is deficient in terms of vitamin D, in terms of making bone, that can cause weakness inherently in the bone and cause fractures. Now let's dwell into the thoracolumbar region classification. So A0 is transverse process and spinous process fractures, which are generally stable fractures and don't need any support, and they can be mobilized immediately. If you have an A1 type of fracture, that is an superior end plate only fracture, and the posterior ligamentous complex is intact, these are generally stable fractures which can be mobilized and can be treated non-operatively. Then you have A2 type of fractures, in which both the superior and the inferior end plate of the vertebra has been fractured, which need sometimes some surgical intervention, or if they seem to be stable on standing x-rays, they can be also managed conservatively. Again, A3, which is superior or inferior plus a posterior wall fracture, these can be also managed conservatively or can be operated if the patient has significant weakness in the nerves. Lastly, if you have an superior plus inferior plus an posterior wall fracture, these are generally managed by surgical intervention, in which we fix the vertebrae above and below and stabilize the spine. Now let's go to type B fractures. These are inherently unstable fractures. So the first one is known as an bony chance fracture, in which you have a fracture going through and through from the posterior to the anterior through the bony part, and these are generally unstable fractures which need to be fixed. And these chance fractures are also known as seat belt fractures, in which if you have a seat belt and you get a sudden deacceleration, your body starts keeps going forwards, and that causes an shear force and causes an fracture in the bone, which is known as a chance fracture. Again, if you have a fracture, if you have a similar kind of injury and you have an injury from posterior to anterior through the ligamentous complex, this is known as a ligamentous chance fracture, which are more problematic because the bone heals and the ligaments are hard to heal, and these are also unstable fractures which need to be fixed. Lastly is the B3 type of fractures, which are known as hyperextension fractures. These are generally seen in patients who have got ankylosing spondylitis, in which basically your whole spine is like an whole rod, in which once it fractures from the front, and these are highly unstable fractures which need to be fixed. Lastly is type C, which is displacement and dislocation of the spine. These are seen in high trauma injuries, and these generally are associated with neurological symptoms, and these are very unstable fractures which need long segment fusion and fixation. Now in cervical fractures, these are similar to what we discussed before in terms of fractures of the thoracolumbar region. So there is an subaxial cervical injury severity score. If it is more than 5, you operate similar to thoracolumbar injury severity score. Here you can see that the patient has got an fracture dislocation of about C4, C5, and additionally on CT scan you can see that there is this fracture of the anterior part. So these are unstable fractures. Even on MRI you can see that there is compression of the spinal cord over here, which needs decompression from the front and fixation. Now this subaxial cervical injury severity score is dependent on the fracture morphology, the discoligamentous complex, the neurological status of the patient, and continuous cord compression. Okay, so if the score comes to be more than 5, you need to generally operate these patients. Now, what you see in bony anatomy is for bony anatomy, you do an CT scan, and for ligamentous anatomy, you do an MRI scan. You need to align and stabilize the cervical spine till you have ruled out cervical spine injuries. Okay, in high risk injuries, like if you have a high risk injury like a road traffic accident, high energy road traffic accident, need to have a spine surgeon who needs to evaluate the patient before the cervical injuries and other spinal injuries are ruled out. Now, in terms of the treatment, what you need to do is if the patient has got an subaxial score of more than 5 and you think that the patient has got an unstable spine, you go from the front as it is done over here and you decompress the spine and you fix it with plates. Okay, you can do it from the back also, in which you have you can put lateral mass screws and fix it after reducing it. Okay, so cervical fractures, if it is stable, you conserve it with a cervical collar with strict follow-up, and if it is unstable, you fix it either anteriorly or posteriorly. In thoracolumbar fractures, if it is stable, you conserve and mobilize. If it is unstable, you fix it as it is done over here with screws 2 levels up and 2 level down with pedicle screws. Now, in terms of the spinal precautions, now if the patient has a suspected cervical spine injury or a polytrauma, how do you stabilize the patient? Is first of all, you need to keep the spine to be kept straight in line and stabilized throughout till the spinal injuries have been ruled out. Now, how do you do it? First of all, you put the patient on an Aspen collar or an Philadelphia collar, which generally stabilizes your cervical spine. And additionally, you put bolsters, which are kind of bricks around the ears, and you strap the patient to the stretcher. Okay, now this is done to stabilize the cervical spine, and this is how you immobilize the patient and shift the patient. Now, how do you do a log roll? So generally log roll is done to examine the spine and injuries in the back. So one person stabilizes the neck. Three people are there sequentially from shoulder down to the legs, rotating the whole body along with the neck as an log of the wood, and one of the person examines the patient from the back. Okay, now cervical hard collar should be snug fitting and it should be re-examined again and again for checking for sores. Okay, there are two exceptions in which you change how you immobilize a spinal cord injury patient. Is first of all, if the child is if it is a child, the head of the child is relatively large than the body, hence a small mat is kept below the shoulders so that the spine is stabilized accordingly, or you can make a small hole in the mat, or you can keep a mat above the stretcher so that the head slightly goes down. And the second one is ankylosing spondylitis or diffuse idiopathic skeletal hyperosstosis. In both of them, basically the spine is like a rod in which it is all fused, and you need to place the spine in its native spinal position as it was before. For that, what you do is you actually put some pillows down his head so that the alignment whatever was present before the injury, in which the neck was a bit bent, has to be reattained. Okay, now in terms of the spinal orthosis, there are spinal tractions which are given. Now, what are the reasons why traction is given? Is for stability and to give the traction and reduce the fractures in the cervical spine. So the risk which are present with halo traction is you can have an pin cutout which needs an regular tightening with an torque limiting screwdriver. You need to keep on cleaning the pin sides. You need to look out for pin migration, which can go and compress on the brain and cause meningeal irritations. So you need to see for that. And this can also cause infection in the skull, which also needs to be looked out for. In terms of the lumbar traction, well, as of now, there is not much use for low back pain based on research, as I told you before. So pain medications Epidural steroid injections and physiotherapy have main role rather than traction is as such. However, if somebody is giving an traction, the basics are you should have a freely movable rope and you should have a counter traction below the uh, bed on the leg side so that the patient doesn't slide down. In terms of the cervical orthosis, first you have the soft cervical collar like this, in which it is generally given only for short term and it is for pain relief. Now you have the hard cervical collars which have more rigid immobilization, and generally they are given for temporary time, and it is generally till you need any fixation or sorry, any fusion of your subaxial cervical spine injuries. If you have a if you need more rigid fixation, you have the sterno-occipitomandibular immobilizer, which is known as a SOMI brace, which is generally gives more stabilization. And if you have a fracture in the C knot, that in the C knot, C1 and C2, then you need an stabilization, which is known as an halo thoracic brace fixation stabilization. Lastly, in terms of the thoracolumbar orthosis, you have the ASH brace, which is anterior spinal hyperextension brace, which is generally given in thoracolumbar fractures. Also, you have a TLSO, that is a thoracolumbar spinal orthosis, which is known as a Taylor's brace, which is generally given in thoracolumbar or in thoracic spine injury fractures. And you have the LS frame belt, which is gives kind of support in the lumbosacral region. Lastly, you have the LS belt, which is generally given for short-term pain relief, as you have a soft collar, which is for cervical region. Thank you. Thanks a lot. If you have any questions, do let me know. And please follow our channel and subscribe to our channel and follow us on Instagram. Thank you. Thanks a lot.